tissue around it degenerates, loses its strength, and the veins dilate. Also because we, during the evolutionary period of probably millions of years, decided we want to stand up and walk. So the four-footed animals, they don't develop hemorrhoids, do they? Have you ever seen hemorrhoid in a cow? No, because they walk on 4 feet. So their anal canal is not dependent for the veins to disgorge or become dilated. It's only in human. So this is an internal hemorrhoid. So this, as long as it is lined by squamous mucosa or epithelium, this is external hemorrhoid. And if it is lined by colonic type mucosa, and here is the squamous mucosa from the lower end, same thrombosed tortuous veins, it is a internal hemorrhoid. Sometimes you might have an invasive adenocarcinoma which presents as a hemorrhoid. It is submitted as hemorrhoid, but you find an invasive adenocarcinoma in a polyp. Actually, several interesting types of tumors can be seen in hemorrhoids. You just have to look for it. Now, that also tells you whether you are submitted with hemorrhoidectomy specimens or they are thrown away. Okay, so much about the non-neoplastic conditions of anal canal. We are now going to go to anal condyloma, squamous dysplasia, and squamous cell carcinoma. So similar to GYN tract, low and high risk HPV infections are causes of condyloma and anal intraepithelial neoplasia, also called AIN, and of course squamous cell carcinoma. The incidence of squamous cell carcinoma is 8 times more common in North America and Northern Europe than in Asia. That's what the statistics says. Here it is 1.7 to 0.2. And clinically visible HPV-driven lesions or condyloma are present in about 1% of population. So that's very common. That's what I was telling you in my third year of medical school. I'm looking at a condyloma and thinking, oh gee, how does this patient defecates? Apparently, it doesn't affect function. Rising incidence rates are attributed to evolving sexual behavior and unprotected anal sex by HPV carriers. And the incidence is higher in women. Now, these are sensitive subjects, and even with a group like you, where I'm a trustworthy person, I wouldn't like to say anything to be politically incorrect. But as I said, a lot of these cancers are due to lifestyle of people, and they have only themselves to blame for it. There are no official guidelines But because of the rising incidence of anal intraepithelial neoplasia, similar to in GYN tract, anal pap smear has been advocated. There is no guideline, there is no official recommendation to have anal pap smears in homosexual males or females who uh, undergo rectal intercourse. There is no official guideline, but there is recommendation. And that's what I was saying. At the end of my practicing career, my lab started receiving anal pap smears, and I was reluctantly, should I say, compelled to start processing them. But I didn't see many cases which were dysplasias. Both AIN reporting, AIN 1, 2, 3 are now changed to low grade and high grade intraepithelial lesions. And there is this management recommended by LAST project recommendations. Like in cervix, HPV subtypes cause cellular proliferation in the transformation zone. Okay, and P16 immunohistochemical stain is the surrogate for HPV infection. So these are very similar to what we have learned in cervix. So how do the anal condylomas look? This is a female patient, obviously, and these are rectal condylomas. But you can see that penile condylomas occur too. So people who are this high risk HPV infected not only transmit it to their sexual partners, they get it too. How do condylomas look? Very similar to what you have seen in cervix. So on the left is a low magnification picture of condyloma, high magnification, typical coilocytes. And I don't need to spend time on this. You've learned this well. Now, you can do, of course, P16 stain, but if you have a fancy lab, you can do in situ hybridization, and all of the infected cells will mark for high risk HPV, low magnification and high magnification. Now, when it is dysplasia already, high grade is here, more or less full thickness immaturity, but no invasion. Okay, so about 25 years ago, I prepared a topic of anal cytology, and this slide is borrowed from that. So these were some of the pictures I took then. Don't look very impressive, right? So this is anal cytology. These are perfectly normal cells. This cell has 3 nuclei. So still I can't diagnose HPV infection here. Here binucleated, somewhat hyperchromatic. So often I would see that diagnostic coilocytes were not present, but cells were not normal like here. So these were signed out in between, ATP of undetermined significance, like here. Anyway, coming back to what I collected to teach you today, there were beautiful articles written on this topic. This is one where pictures of normal squamous cells are on the left, anal cytology. On the right is the upper sampling from the rectal epithelium, colonic mucosa. So this is your baseline. Here on the left is atypical podocytes or low-grade dysplasia. Here also is low-grade dysplasia, and here is high-grade dysplasia. All of these are quite similar to cervix cytology. So I'm going to ask now Dr. Ferdowsi, anybody sending you anal pap smears?
No, sir,
Not yet.
not yet.
No. Sooner or later you'll receive it. But it's similar to cervix.
Sir, I have a
And
question.
yes, go ahead.
Sir, in the cervix, the cervical smear, it's easy to make the smear, I mean, the conventional smear, because the mucus is there. Um, because of the mucus, the smear, we can
I
make
know.
the smear. But with the
I
anal,
know.
I think liquid-based cytology may help.
Yeah, you are very right, because once they started practicing anal cytology here,
Yes,
regular
sir.
smears become extinct. They're all liquid based. I think you can prepare though, because what is done is the entire anal canal is sampled all the way to the rectal end. I think smear can be made, but without
Yeah.
preparation, it's going to be full of feces, I can tell you.
Okay, nobody has started it yet, but yeah, maybe in the future.
Yeah, but nothing to look forward to. It's not going to be pleasant.
Okay, sir. Thank you, sir.
Okay. Oh, so here is the low grade of anal squamous intraepithelial lesion, and here is your high grade. On the right is combined stain of both for the virus and for the mitotic count. So these are becoming very fancy or common nowadays in the United States and Canada. Combined or multiple antigen immunostains. So here they combine P16 with Ki67, double immunohistochemical stain, and the darker cells are dividing, and all the bright pink cells are picking up P16. So this is the section here. Okay, some gross pictures of obvious squamous cell carcinoma of the anal canal. This is an abdominoperineal resection. Okay, so quite a length of the sigmoid is here. And of course, this is the cancer infiltrating full thickness of the wall. And this is the tumor. And sections will show this one is beginning to infiltrate is the inner surface, and in the infiltrating sections may have different looks. This is a basaloid look, or what I call a cloacogenic look. This is keratinizing look, and in here also there is clear cell features. So all these things can be seen in anal squamous cell carcinoma. Depending on if it is all mixed up, it's still just a squamous carcinoma with different features. But when and if you see primarily a basaloid appearance, then I call it cloacogenic carcinoma. I'll show you a picture of that. As I told you before, the surrogate stain is P16 stain. It stains very well. Here it's all block-like positivity. Each and every cell is positive. Whereas this one, mottled focal P16 expression, considering this case as a negative staining. This result argues against diagnosis of high-grade SIL. So if you have this kind of staining, whether in cervix or in anal canal, this is not high grade. It might look somewhat eye-catching on the HNA, but if there is no block-like pickup of P16, this is still low grade. Now, this would be a good example of what I call cloacogenic type of squamous cell carcinoma of the anal canal, or basaloid non-keratinizing squamous cell carcinoma. There might be a foci of keratinization like here. This is a neuroendocrine tumor of the anal canal, colonic mucosa normal, and here there is unescapable neuroendocrine look. And if you do your neuroendocrine marker, synaptophysin or CD56 or chromogranin, it will pick up. Slightly more than 1% of all anal cancers are neuroendocrine neoplasms. I think we are done, and I'm ready for questions. Any suggestion, any discussion? As I talked to Dr. Ferdowsi before you all joined, hopefully end of December, I think it's 28 December is a Friday. We'll cover the esophageal lesion, and then we'll conclude. And let's see what happens in the new year. Hopefully we can look forward to something better in our country.
Sir, I have a question.
Bola.
Sir, the cloacogenic term, the term cloacogenic, I mean, I was confused, but after listening to your lecture, it's mainly, sir, the non-keratinizing squamous cell carcinoma. That means cloacogenic carcinoma.
Yeah, essentially tumors which look very basaloid. You know, if you have seen enough anorectal cancers, you will see some of them are extremely basaloid. The clinical importance is that that particular tumor prone to metastasize to inguinal lymph nodes.
Okay, sir.
And so inguinal lymph node is either sampled by FNA or by biopsy. and we start worrying about where is this tumor coming from,
Yes, sir.
because it looks somewhat like small cell malignant tumor. And unless
sir.
you know this entity, you don't tell the clinician, go look in the anal canal.
Yes,
So
sir.
that's the importance of cloacogenic carcinoma.
Yes, sir.
Good question, brought up the topic of what I wanted to tell you, that it goes to inguinal lymph nodes.
Yes.
Yeah, thank you, sir.
You're welcome. Okay,
Thank you, sir. Thank you,
I
sir.
want another brilliant question. Who wants to ask?
I found a case of acynic cell carcinoma arising from the anal canal. Is it possible?
Oh, so that could be from pancreatic rest.
Oh, okay. So,
I think, yeah, all kinds of things can happen, but pancreatic rest can occur anywhere in the GI tract.
yes, sir, that is possible.
Yeah.
Sir, I have, I can't remember exactly everything, but that was a female. She has a history. I mean, she was operated uterus, cervix, vagina, and then rectum, anal canal. And the problem was, where is the primary? Is it anal canal cancer invading into the vagina, or it's squamous cell carcinoma from vagina or cervix invading into the anal canal? This part I can remember.
Well, advanced cancer,
Yes, sir.
the CT scan has to tell. What is the epicenter? It has to be the imaging. We really cannot tell just by looking at a sample.
This is a 10-year-old, 10 days old baby.
And I think immuno also is
I
not
know.
going to help in this case.
No, not in squamous cancer,
Yes,
because bulk of these tumors will mark for HPV,
yes, sir.
whether cervix or anal canal. And even if it doesn't mark, I don't think there is enough confidence level to say it is not cervix invading.
Yes, sir.
Manohar, any
Sir.
suggestion, any input?
No, sir.
All right. So
As
then,
well, my observation is that, sir, that squamous cell carcinoma of anal canal is not very common in our country. We don't get it often.
maybe because it's HPV infection of anal canal may not be as common, or the other reason is people just don't come with this early
Yeah.
enough.
Yeah, that may be the reason.
Yeah.
Yes, sir. Thank you, sir.
You're welcome. So I'm going to stop recording now. Now I see the grid view.
Yes. Sir, I have to leave now. I have a case now.
Sure, Manohar.
Okay.
Okay. Today is Friday, so have a good weekend.
Yeah, thank you, sir.
All right then. Take care, everybody.
Thank you, sir.
Thank you, sir.
Thank you. Thank you, sir.
Assalamualaikum.
Thank you very much. Thank you, sir.
Thank you, sir.